one of our, big projects with the Appalachian Pulmonary Health Project is to get people accurate testing and diagnosis earlier. And so we grabbed this case just to show that sometimes a spirometry and or a full pulmonary function test should be ordered earlier in the game. But so I'll just go ahead and get on with the patient. All right, he's a 45-year-old male. So in November 2018, a 45-year-old white male comes to a rural health center for his initial visit. He wants to establish care for his poorly controlled type 2 diabetes and his erectile dysfunction. He reports smoking 1.5 packs per day for 20 years. He has part-time work as a truck driver. On review of symptoms, he reports mild dyspnea on exertion and cough. He receives baseline labs and scripts for metformin, ACE, and statin, and a 1-month follow-up. He is next seen 5 months later. He is complaining of difficulty sleeping. He reports drinking 12-pack of beer per day. He receives the scripts for bupropion. 1 month later, 5/24/19, he presents with AFib. He is referred to the ER and admitted. Chest X-ray shows pleural effusions, echo global dyskinesia, ejection fraction 38%, negative EST and scan. Discharge on diltiazem, apixaban, Eliquis, metoprolol. His hospital follow-up is 6/6/19. There's no change. Next visit is 10/10/19. ALC is 11.3. Main complaints are erectile dysfunction, depression, and palpitations. 3 routine follow-ups in 2020. He is complaining of increased dyspnea on exertion and chronic lower back pain. Bedtime HC is 7.5 milligrams prescribed. Bedtime hydrocodone, is 7.5 milligrams prescribed and referral to chiropractor. He attends a series of chiropractic visits. He requests second opinion with cardiologist to obtain ablation for his AFib. In October 2020, a PFT was ordered. So his comorbidities are depression, AFib, hyperlipidemia, diabetes, back pain, former smoker with a 30-pack year history, congestive heart failure. His weight is, he's 5'10", 255 pounds, blood pressure 132/86, and his SAT is 98% on room air. You want me to, okay, the physical exam. I did the blood pressure. General appearance is healthy appearing, well nourished and well developed. Level of distress and AD. Ambulation, ambulating normally. Psychiatric insight, good judgment. Mental status, normal mood and effective and active and alert. His lungs, no dyspnea. It says respiratory effort, no dyspnea. Auscultation, no wheezing, rails, crackles, or rhonchi, and breath sounds normal. Cardiovascular, heart auscultation, no murmurs, and irregularly irregular. No edema. Medications, cardiazem, Eliquis, propafenone, glipizide, metoprolol, Symbicort, and furosemide. So now we'll get to the pulmonary function test. I always like to see the actual PFT, so if you don't mind pulling that up, Mithra. Okay, so this is a gentleman with a really, long smoking history, although young, had never been ordered a pulmonary function test. So we have his FEV1 raw pre-bronchodilator is 1.94. I'd like to, I'm sorry, you can just pick. Sorry, Dr. Doyle's answering my phone. So I'm going to just put down,
Yeah, go ahead, Doctor.
I'm going to go ahead and just go from this screen, okay? So our forced vital capacity, 60% of predicted, FEV1 is 47% of predicted, and obstruction is confirmed with the FEV1 FVC of 61. Lung volumes, 58, the total lung capacity is 58.
Yourself a half hour or something on the app, and we'll look at what you do. And that'll kind of be your pulmonary rehab for today.
And our diffusion is 64. I'm just waiting for him to pause. Post bronchodilator, there is significant response with the 13% improvement of forced expiratory volume in the first 1 second. That raises it to 53. So it's gone from severe obstruction to moderate obstruction. And this is our case. So the questions, which, you know, to me, whenever he said, and I would probably leave that up, Mithra. I think it's a great PFT to look at. But when someone says that they're really short of breath and you get something like that, then you know exactly why. Although, you know, the AFib absolutely contributes. But so our question is, start with 5 and 6. Yeah. In order of priority, what are this patient's main problems? And what should be the PCP next steps with this patient?
Well, first, Lisa, that was awesome. Thank you so much. We always love cases, and that was extremely elaborate and great. So thank you very much. Any questions about clarifying the case or anything? If not, we can just jump right into some of the recommendations from the hub members regarding that first question that they had. And feel free to chat in as well. I can read out the question for you all. I'll leave this, this image up as well to take a look at. Lisa, would you mind reading the question again? Maybe some folks could hear it again.
You could put the questions up on the screen.
Mithra, I guess you could go ahead and put the questions up on the screen. And then, so the main question, or the first question, is in order of priority, what are the patient's main problems? And what should be the PCP's next step with this patient? I started at number 5 and 6. And then you can go from question 1, 2, 3, and 4.
Excellent, thank you.
I'm sure Dr. Seal will chime in.
So I don't see any inhalers. Is that correct? I saw mostly.
We have there's Symbicort.
Symbicort. Okay. So you know, even though he had a bronchodilator response, it was not a complete response. So I would classify this patient as having COPD rather than asthma. And so, you know, first line medication is going to be a LAMA. So maybe adding something like tiotropium would be a good start for this patient as well. And then also probably a short acting. And I would also argue that not only does he have COPD, but there appears to be some restrictive disease as well. Do you know at what point he had the pulmonary function tests? Did he have pleural effusions when he had the pulmonary function tests?
His PFT was done on 10/27/20. So I'm thinking that chest X-ray was in 2019, in May of 2019.
Okay, so it was a year
when
ahead.
he was in the ER. So he's not had another chest X-ray.
That's a suggestion.
Yeah, that's a good suggestion.
And that's a great point, Allison. Like, where's the follow-up chest X-ray to see if the pleural effusion's ever resolved?
Yep. What about has he had a, I'm just sort of looking through everything. And what else pops to my mind is polysomnography with his difficulty sleeping. We know that with atrial fibrillation, you can have sleep apnea very closely associated, and then also untreated sleep apnea can lead to some shortness of breath as well. So that would be something else that you'd want to look into as well.
We do have a referral in for a sleep study.
Okay.
But it hasn't happened yet.
Okay.
I don't notice.
And Lisa, did you want to ask the other questions as well, or did you want to still address those ones?
What's the contribution of COPD to AFib? What is the goal grade and group? And okay, and then Dr. Sela answered number 4.
Awesome, thank you. We did get a question from Grace Ann asking if he is in a smoking cessation program.
He was given information. He has quit. No, he has quit since then.
Awesome, thank you. So any,
as far as his gold stage, his FEV1, you know, like we said, puts him at a moderate with his FEV1 of 53%. Did we have a CAT score or a history of exacerbations? I know he was hospitalized for his atrial fibrillation, but I didn't see where he had been hospitalized for any COPD.
That's right.
Correct.
That's right. And I think we have no known exacerbations.
Okay. So, I mean, so here it says, oh, where does it say? Mild dyspnea on exertion and cough. So I don't know if that would necessarily correspond to a lower CAT score or a lower MMRC. If that's the case, then that would actually probably put him in a COPD group A with no exacerbations and minimal symptoms.
Okay, thank you, Dr. Sela.
His grade is 2, like you said, Allison, grade 2, moderate, and then his group is A, so he'd be 2A. And I guess we could, the symptom classification on that gold table takes CAT or MMRC. So I think, like you said, he's got mild dyspnea, so I'd give him an MMRC of probably 1 or 2, but still you wind up with 2A. And we put that in because I'm still on my campaign to get all of our sites to use that scoring system with people.
thank you, Dr. Doyle.
And I'm curious, though, among other people, I'm curious. Allison has addressed, you know, most of the pulmonology and COPD questions, but from a primary care perspective, and Dr. Roby, I'd love to get your input on this. There's also the question of in terms of the big picture, lung disease is a serious problem, and it took us a long time to detect it. Great example of delayed diagnosis, we think. That's why we presented this case. But in terms of the big picture, there's a number of issues about this patient in terms of his primary care, his lifestyle, his risk factors. And for those of you out there who are primary care providers, and I don't know who all else is on this call, I can't see the whole group right now, but Dr. Roby, you're there. And actually, Dr. Clegg is right here with us. I mean, how should the PCP interact with this patient? Here's some, and I'll resist giving my interpretation. I'd like to hear from other people just about the big picture management of this patient.
Yeah, Dr. Doyle, I think a couple of things that came up to me. I mean, anytime, you know, I see a truck driver, I start thinking of, you know, some guy that's eating fast food and stopping and eating on the road and that type of thing, and, you know, not able to have great access to great nutrition most of the time, particularly if he's driving, you know, long rides and stuff, and, you know, A1C of 11.3. But the other thing is obviously the alcohol, and obviously, you know, beer is not carb free, so obviously that's contributing to the A1C. But the EF of 38%, and you know, with the underlying, I'm assuming, you know, negative stress test and scan. So I'm assuming it's just being determined to be some type of alcoholic cardiomyopathy, perhaps, or whether there was some other underlying, whether viral or something else going on with the EF, is a little concerning as well, just kind of from a non-lung standpoint in what I'm looking at.
Thank you, Dr. Roby. That's excellent. Lisa, were there any other questions you wanted addressed about this case, or anything you wanted to discuss about this case?
No, that's great. We can wrap it up. I appreciate you guys so much.
That's awesome. Thank you so much. We appreciate you. It's awesome having a case submitted and everything. We love it. So did anyone else have any questions for Lisa about this case? It's open for anyone to ask questions as well. All right. Awesome. Well, thank you again, Lisa. That was great. And thank you all for, you know, chiming in and giving the recommendations and stuff. So that's great. Dr. Roby, I can pull up your didactic for you, and I'll just turn things right over to you. Let me know when you'd like me to advance your slides for you.
All right. Thank you, ma'am. So I thank you guys for letting me come today, and definitely want to make this kind of a regular, a recurring visit for me, because I think you know, having more people involved in this kind of communication, I think, will be very helpful. So we'll see what we can do to help along those lines. Dr. Doyle asked me to come and just give maybe COPD maybe a different slant, looking from a population health perspective. As I mentioned in my introduction, I'm Associate Chief Medical Officer at Charleston Area Medical Center, and my main responsibility is with the West Virginia Health Network. If you look at the next slide, we now have almost 1,200 plus primary care and specialty providers in our network, with 15 hospital locations throughout the state, and 15 different organizations participating in our post-acute collaboratives throughout the state, with many of the nursing homes and stuff. You know, some of the larger hospitals the hospitals that are involved with us is, you know, Mon General and their 3 hospitals associated with them, Roan General, CAMC's 4 hospitals, Thomas Health Systems and their hospitals, Plateau, Greenbrier Valley, and Princeton. So kind of we spread across the state, and what the West Virginia Health Network is really a clinically integrated network. So basically, underneath our umbrella, we have an ACO, which is an accountable care organization, which works with straight Medicare patients. But in addition to that, we also have quality contracts with all 3 of the Medicaid programs throughout the state, several of the Medicare Advantage programs throughout the state, and a couple of commercial plans as well. And basically what we do is we try to coordinate the care of the patients at a much higher, larger level. So, you know, as I mentioned, we have some large hospitals throughout the state, but we also have some rural health clinics and some FQHCs that are part of our organization as well. So we really go, you know, from the very large hospitals all the way down to the smaller rural health clinics. And it's interesting to see us collaborate together. And I think most recently, one of the biggest collaborations, of course, has been with a lot of the COVID-19 going on. And just to give you an example, we spend 2 phone calls a week just working through collaborations of different things. And just to give you a taste of what we're doing right now is we're working to develop what's called relief hospitals and relief clinics. And these hospitals and clinics are going to be able to try to take some of the weight off the larger hospitals that are dealing with large influxes of COVID patients by helping us take care of some of the non-acute type patients that can be taken care of at the smaller hospitals. And then as far as the relief clinics go, those are clinics that are going to be able to help take people out of the ERs and allow us to discharge patients earlier to home to be able to free up bed space as well. So that's just kind of an idea of the collaboration that we do at the West Virginia Health Network. If you look at the next slide, this slide just kind of shows the complexity of population management. And I guess maybe it didn't copy over well. It's one, okay. I forgot how fancy I got. So you can see with the regulatories and the payers and the care management and the clinical integration of the data. And before long, when you start trying to look at population health, it just gets very complicated and lots of different spokes that come out of trying to take care of an entire population. You have the difficulties with clinical integration, and I'll talk a little bit about the different platforms and stuff that we try to use, but you can imagine getting, payer data, pharmacies, all the different EMRs that are out there and trying to get those all aligned into the same area. So it just kind of shows really the complexity of what population health is. If you go on to the next slide, what we use at the West Virginia Health Network is what we call Healthy Intent, which is, it's a Cerner product that allows us to bring in data from all kinds of different sources and try to get them integrated into one type of platform. So we can take data from pharmacy data, payer data. We even have the ability in the future to bring in data from different devices that the patients are wearing. Of course, we bring in lab data. All this kind of data comes in, and it kind of connects with the longitudinal medical record that all of our patients have, and we try to overlap the two together. So one of the biggest challenges over the last year and a half has been getting all the EMRs to talk together and be able to get all that data into one location. And though it's been tough, by the end of this year or very early into the first quarter, we'll have all of our ACO partners data into one platform, which really gives us the ability to be able to look at things, and I'll show you an example of that in a second. But it also gives us the ability to use kind of some artificial intelligence and some algorithms to try to predict what patients are most likely to need intervention. So, there's one thing in population health to try to work with care managers and different people to fix things after it happens. But with all that data, shouldn't we be able to figure out which people would, benefit from different things such as PFTs and those kind of things before they actually have exacerbations and they end up in the hospital, and we miss those types of things. So it's not just a matter of getting the data into the system, but it's also, the matter of being able to use that data to come up with actionable items for whether it's the clinicians, the providers, the care managers, perhaps even down to the health coaches or community care members. So if you kind of look at the next slide, I think, when we start talking about spirometry in particular, and we think about, in population health, how can spirometry, benefit us? I think, obviously we use it for baseline data and diagnosis, and I'll talk a little bit more about the importance of the diagnosis in regards to population health. We use it for risk stratification, just like I talked about, but it also allows us to develop with our care managers some focused treatment plans moving forward. But spirometry isn't the only thing that we look at, particularly with COPD patients when we do population health. And what I'm showing you on the next slide is a brief example of one of our dashboards that is in Healthy Intent. And these are the things that when someone triggers into the COPD registry, the things that would get them there is obviously a diagnosis of COPD, but also if they're given a prescription for asthma, whether they're given a short acting or they have, different findings that would lead to the question of COPD, they will end up in the registry for us to evaluate. So some of the important things that we look at, of course, is pneumococcal vaccination and influenza vaccination in this group of patients. And you can see, looking at about 15,000 patients in the influenza and about 6,000 or so patients in the pneumonia vaccination, our percent of immunization is not very high according to this dashboard. Now, this is where in population health, though, you also have to think about where your data is coming from. So this is mostly EMR data and some payer data. So there's still the possibility that patients go outside and get their vaccinations at pharmacies or different places that may not necessarily be recorded in the EMR. Now, you would imagine, though, that most of those would be caught in the payer data. But what happens if they go to a free flu testing event, or they go somewhere where flu shots are being given out for free at the grocery store, at the senior citizen event? So we'll miss those initially, and the hope is that when those patients come into their primary care visit next time, those can be documented as history. So the one thing that as we dive into population health, it also teaches us a lot about how we document things in our EMR and sometimes the lack of how we document things in our EMR. So you can see in particular spirometry evaluation, only about 23% of our patients have had spirometry. So this looks at about 15,000 patients throughout our health network that would qualify or be appropriate for spirometry, and only about 23% of those have met that criteria. Now, the same kind of thing can be, thought about in regards to the flu shots that, perhaps they went to their pulmonologist who is outside of our network, had a spirometry test done there. The spirometry was sent, via a piece of paper on a fax machine to the primary care office, but they never documented in a way that it could be captured within their EMR. So there are still downsides to this, but this at least gives us a starting point of where to look. I think the one thing that we're learning is the more payer data that we're able to pull in, a lot more of those things that are done outside the realm of where our data is captured are able to be figured out and captured. So, if a patient has Medicare and they go and get a spirometry at the pulmonologist who's outside of our network, we'll still get on the payer data that Medicare paid for a spirometry. So we may not have the report in our EMR, but we would be able to see on our dashboard and in our suggestions for the patient that he did have that test done. And you can see some of the other things that we do look at is corticosteroid therapy and the amount of patients that have received that, particularly those that have received it on admission. We look at tobacco use screening and cessation. So there has been in about 74% of our patients tobacco screening, which really, if you guys are on the front lines, you realize that that's a pretty mandatory click in most EMRs. So I'm not surprised that it's that high. But that's just the screening. It doesn't necessarily mean that we've gotten them to stop smoking, obviously. But again, you could use that list to help you kind of figure some things out, as well as, semi-annual office visits and long-acting bronchodilator therapy, which I find it kind of interesting after I did this dashboard last night that 100% of our COPD registry is on long-acting bronchodilator therapy. I think there's probably some error there in the data that I'm going to actually look more into, because I found that was somewhat unlikely that 100% of our patients are on long-acting bronchodilator therapy, but I'm going to look more into that. So that just kind of gives you, when we think about COPD from a population health perspective, obviously the spirometry is a big part of that, and getting that for us to assist with the diagnosis, and those types of things are important. But, from a population health standpoint, the immunizations, the immunizations, and then even some of the therapies and those types of things are important for us to look at as well. So, I kind of mentioned about risk stratification, and this next slide is something that I kind of use to help explain to people how ACOs and other value-based programs work. So if you think about an ACO, and when we talk about Medicare shared savings, basically Medicare says, for patient A, it should cost you $10,000 a year to take care of patient A. If patient A spends less than $10,000, then you would be possible to get some of that savings. And if they spend more than $10,000 a year, then depending on what type of contracts you're in, you could be held at risk for that payment, okay? So how does Medicare or any of the organizations figure out how much that patient should cost? Well, what they do is they use what's called HCC coding and develop a risk stratification score. And I think this kind of lays out in kind of a very easy, viewable way of what this looks like in regards to cost and those types of things. And I bring your attention down to asthma. So you can see if you simply just code asthma on your patients and don't actually code, for instance, COPD, you move from a score of 0, and then if you would use COPD, you go to 0.328. You know, I think the other kind of area is if you would document a pressure ulcer to the right heel unspecified, that doesn't really trigger any risk factors for Medicare. But if you put pressure ulcer right heel stage 3, that's a big deal. Same with obesity. If you were just to code obesity, perhaps in the case patient that we saw, and you didn't actually code morbid obesity, BMI of 42, there's a big difference in the risk score. So what does that all mean in the end? Well, if you looked at the patient on the left who kind of had non-descriptive, very bland type of diagnoses that honestly a busy primary care practitioner would use and grab all the time because they happen to just be on their problem list or on their favorites, he would only have a RAF score of 1.029, and the RAF score is kind of that risk stratification score. The higher the RAF score, it's predicted that the patient would have higher cost. So if you look at the first patient, Medicare or whichever plan you have would say that that member should cost about $9,000. Whereas if in option 2, when you coded things appropriately, it would actually be $32,000. So that's a big difference when you're talking about figuring out cost savings and the possibility of loss as a lot of us move from, you know, just fee for service into actually more of a value-based contract. So it really does make an impact. And I know, you know, some of the FQHCs and rural health clinics, you know, at times aren't as concerned about what this looks like. But when you're involved with an ACO, for instance, like I said, we have 2 very large FQHCs in our ACO and several rural health clinics. It does make a big difference, perhaps not on the payment of the visit, but in the possibility of shared savings or shared losses down the road. So you can see if you have a patient that comes in and he just has some shortness of breath, you listen to him, you hear a little bit of wheezing, and you just say, oh, he's got asthma, I'm gonna put him on a bronchodilator and he'll be good to go. It's really important to get that spirometry, as many of you guys know. I mean, I feel like I'm preaching to the choir here, but it's important to get those types of tests to make a full diagnosis, you know, of exactly what's going on. So kind of in closing here, and then to open up for any questions, I just kind of wanted to kind of go through. So, you know, the last part of that first slide that I showed you as far as the data and then integrating into one, we talked about action plans and getting our data to be actionable. So what are we doing at the Health Network using healthy intent to find actionable items? So if you look at the next slide, you know, obviously one of the things that we do is we educate our team on HCC coding and the importance of getting the right diagnosis. And part of that is figuring out ways to increase the access to spirometry for these rural health clinics in different areas. You know, and it was so great to make the connection with Dr. Doyle a couple months ago, and, you know, really look forward to how the West Virginia Health Network can really get involved with this group to try to increase that availability of spirometry and also get patients connected to where the spirometry already exists, where sometimes people don't think about it actually being existing there. We work hard with our care management programs. We have several care managers that are on site with the West Virginia Health Network that do a lot with post-discharge calls, transition of care calls, as well as care management calls, just to really touch base with these patients, see how they're doing, monitor their progression with their medications, make sure they're compliant with their medications, and really make some of that. One of the things that we look forward to in the future is trying to develop a better community health workers program. You know, in the state of West Virginia, we have lack of access to clinics at times, difficult to get to areas. So one of the things we're working at is how can we increase in some of our rural health clinics and FQHCs, you know, even a bigger presence of community health workers to really get involved with these patients. And we find that a lot of times if they can make connections to people actually in their communities, they listen a little more and they become a little more attentive. And then of course, one of the obvious things that we continue to try to do is use our data not to be as retroactive, but be more proactive in reducing ED visits as well as readmission programs. So we actually have some analytic programs that can help us kind of trend when, you know, example of a COPD patient has, you know, gone to their primary care doc a couple times, has been to an urgent care a couple times, and they really need a little bit more intense service. So we can generate lists that kind of show these patients that have a high prediction of being admitted to the hospital, and what we can do to kind of on the front end really try to make an impact on that. So that was a really quick overview of kind of what we're doing at the Western Health Network, how we look at COPD, kind of from a more of a population standpoint than an individual patient standpoint, and some of the things that we're doing. So I'd be more than happy to answer some questions if you guys have any.
Well, first and foremost, thank you so much, Dr. Roby. That was awesome, and the population health perspective was so great. I'll definitely have to reach back out to you to add you to the 2021 curriculum at some point. So any questions for Dr. Roby and the didactic he just gave? Feel free to chat in as well, and I can read it out. Dr. Doyle, was there anything you wanted to add as well?
Well, what I always add is allow silence because people will ask questions, and we have 15 minutes. There are definitely questions, but I'm going to hold off for a couple minutes.
Absolutely, that sounds good to me. That's the new adjustment I've had to make with Zoom as well. Kim, was there something? Mm-hmm.
Yeah, I just wanted to know, and I really appreciated the presentation and an update on where we are with the ACO network. I just wanted to check and see, does that system currently interact with data from WVU?
No, so WVU, they have their own ACO and work within their own collaboration with WVU Medicine. So we don't have any, the only connection we have with WVU is with the WVU Physicians of Charleston group. They are part of our ACO because of their integration into CAMC, but we don't have any WVU data.
And I'm sure you understand why I'm asking. You know, it's like our clinic at Jackson General, you know, some patients that live in Jackson County get some doctors specialty care in Charleston, some specialty care in Parkersburg, and it's just really hard to get a full picture of a patient when they're going into two systems that don't talk to one another. So I was just hopeful.
Yeah, maybe one day in the perfect world, those systems will be able to communicate, but I don't see anything in the near future that makes me think that we would have full state integration. I think you kind of have your WVU and WVU Medicine, and then you kind of have everybody else. And if you kind of looked at our map, we're kind of turning into everybody else. So I wish there was a better collaboration there.
Can I ask a question verbally?
Absolutely. Yep.
So how does the diagnostic information get between different parts of the ACO? Like if they get spirometry that is known about by their primary care provider out in, less Overshoe, West Virginia, how does that information follow them to their hospital admission at, in one of the major centers?
So one of the things that we're building that is being built within the Healthy Intent product is something called Healthy Record. So Healthy Record actually is kind of that classic longitudinal view of what we're used to seeing in medical records. So that kind of gets connected through the Healthy Records of the Cerner Population Health Platform. Now, for instance, as the other person just asked, I mean, obviously if they go to, one of the Mon General hospitals like Preston, and they get that done there, and then they end up at Morgantown, obviously the Healthy Care is not going to do a thing for them there. There's no integration there. So the one thing that we've kind of really began working with is the West Virginia Health Information Network, and start working with the West Virginia HIN to really make sure that we're maximizing everything we can, so that even if patients do end up outside of one of the multiple ACOs and their population platforms, what would it look like though if the West Virginia HIN was one of those answers of how that diagnostic test like that gets to those other facilities. So I think we've done some pilot projects with the West Virginia HIN in different areas, particularly in regards to nursing home and ED and that type of transfer back and forth. But I think one of the things we've been talking about is how can we start working with the West Virginia Health Information Network, which is our statewide HIN, to really make those things available, because I think that's so important.
Thank you so much for the question, Carl, and thank you, Dr. Obi.
Okay,
Dr.
I'll ask
Doyle?
my question. Yeah, I'll ask my question. I got a couple simple, well, the first one's simple and the second one is kind of simple, but like Kim Tieman's question has some big implications. So Dr. Roby, thank you very, very much. I really appreciate that you did this. It gives us a big picture that we don't have on the front line, particularly in terms of our special focus in the at the Grace Andorni centers and in the APHP, which 95% overlap, at delivering primary care frontline good preventive and rehabilitative care. So you said that there were in the West Virginia Health Network, you showed us the dashboard for COPD, that you identified 15,000 and something patients who were appropriate for spirometry, and of those 23% got it. What's the big denominator? What's the covered lives?
65,000, 70,000. It's about what we're up to now.
Okay, so in using your screening protocol, that's about 20%, 20-something percent of all patients were identified as being candidates for spirometry. And my guess is that's because they're smokers. And so that makes sense. And you have children also, right? So those 70,000 lives include substantial numbers under 18.
Yeah, and we also, some of those lives may not have been, they're not active in Healthy Intent yet. So after I said that number, I mean, there's some handful of patients that aren't in Healthy Intent yet.
People get mad at me for putting them on the spot, but sometimes I just go ahead and do it anyway. And I'm really, and that kind of like, no good deed goes unpunished, I think is the relevant saying. So Krista Clark and Luann, your good deed is that you showed up. Thank you.
You're welcome.
Question though, do you think that the spirometries and pulmonary function tests that you're doing at Cabin Creek, and that I can go into Athena and see if I'm treating those patients, do you think that those spirometries, and I want you to make your best guess, and then Dr. Roby will give us the answer, but do you think that the spirometries that we do, the many, that we do at New River and Cabin Creek, and that we have in our record, Lisa Emery just showed you one with this case, are showing up in Dr. Roby's West Virginia Health Network data. What's your belief about that? Go ahead.
I'm not sure that, hold on, we've got two. I'm not sure I understand the question as far as showing up in his data. Could you?
Okay, so Dr. Roby told us that of 70,000 patients in the West Virginia Health Network, their data suggests that 15,000 of them should be getting spirometry, but only 1/4 of them, one in 4, which is something like 3,500 out of 15,000 actually get it. But he mentioned that it is possible that spirometries were being done on paper and that a fax image of those was in the record, but that the way their data system worked, those simple faxed reports, like for example, if Allison had a faxed discharge summary in her record from a WVU, from a patient admitted to Ruby, there's no way that we know of that Dr. Roby's population health data would even know that. So my question is the work that we're doing to provide pulmonary function tests at Preston Memorial and at Cabin Creek and at New River, is that totally missed in that 23%? Are our people in the 23% who got it or not? Carl, you can weigh in on this too if you want.
So I'm noticing when we do in fact, that was something we talked about this morning, is we're going to run a report on the smoking population within the sites, because we were told, what, a year or two ago that 50% of our patient base are smokers. So having said that, if 50% are, then our bucket should be overloaded with spirometry requests, and we don't see that. So I would think that it is true that the amount that should be getting it maybe aren't. The other side of the coin is that they sometimes have a provider, maybe they have a pulmonologist, but they don't tell us, or they also don't get the copy to us. So then that's something I'm going through right now, is going through a list to see, are they seeing somebody else and we just don't know that? And because they don't send us the reports. There's a couple groups that we're working with to try and make sure we get those copies, so at least we know that somebody's getting a spirometry test. So
my question is, if we're taking care of them and we did it, does Dr. Roby even know
it? I don't know that.
So I can help you out. I can help out a little bit with that.
Yeah.
So
my question is it financial or medical records, because they're very different.
Yeah, so just quickly on the Cabin Creek, I think that's an interesting exercise to go through, because Cabin Creek is part of our ACO. So looking at what we have for Cabin Creek data, and we do validations of data and that type of thing as we onboard them in healthy intent. And we're in the process of that with Cabin Creek. So the question is, one of the things that we should do in our validation is actually look and see if the spirometries that are being done are being captured. And a lot of times, if it's not, it's very similar to what you said, Dr. Doyle. What our healthy intent goes and looks for as a population health platform is usually check boxes or some type of code entered or that type of thing. If there's a scanned piece of paper in the chart, it's not going to be able to read that scanned piece of paper. So I think that's part of the validation that we do with these practices, is to kind of figure that out.
So I would say at Preston, ours are not being counted because our system is not integrated in. All of our pulmonary function tests are hand read by me and then scanned in separately. And the reason for that is because we looked at integrating all of our systems, our EKGs, our echoes, our pulmonary function tests, and it was over 10 grand each to integrate each separate test. And so at Preston, we have a system that's working for us. And so unfortunately, it's not directly integrated and, directly scanned into our system.
And that's where the payer data comes in, because it is very difficult to integrate a lot of these systems in. But the one underlying defining thing that typically happens is you end up billing for that service and you end up getting paid for that service. So one of the things that we're striving for is, and I think we're very close with getting Aetna, Medicaid into our system, is getting the other two MCOs into our system. So then when those patients at Preston get billed for a spirometry, we see that on the payer side, and that gets incorporated in, and we can then check that box that they've received their spirometry through the billing data.
This is Krista. I don't know if this might work. We use Athena, and I think Lisa at New River, they have Athena as well. But I'm just trying to think in my head, there's certain like boxes that have to be checked off or things selected, say under their social history with like smoking or alcohol use or, you know, whatever it may be. But maybe under those types of questions, especially if they are a smoker, I don't know if it can be auto-populated in, but maybe that would be one of those check boxes that we need to complete to reach those quality measures. And I don't know if that would help, you know, kind of with that integration or whatever, that it would kind of flag you guys or even us.
Yeah, no, that's exactly what you have to do.
Okay.
That's a great idea, Krista.
So, but are you, wait a minute. Are you trying to pull data that's, do you care, you actually at this point, for the data analysis you're doing, you don't really care about what the result of the spirometry was, just that they had it. So is there some reason not, I mean, you know, even if the system manages everything on paper, the billing is still electronic, and you're going to, I mean, if you can suck the data out of the Cerner Sister Preston and Athena down in the Cabin Creek system, you're still going to get data that they had spirometry, assuming that their CPT coding is accurate. Is that, am I missing something, or is that how this works?
No, that's how that would work, yeah. So I don't necessarily, when we use the payer data, able to tell you the severity or the diagnosis is pulled from those PFTs. You know, that's at a different level. This is just at the population health level, figuring out, are we at least giving spirometry of the patients that need to have spirometry? And I think that's what this answers for us. And billing data does that for you.
This is Luann.
Do you also get the billing data from these outlying clinics that from across the ACO, or do you just see it from the payer side?
So we get 835 data from the clinics. So we do pull what they submit for billing as well.
Luann, was there a question as well? We have time for one more question.
Sure. Actually, it wasn't a question. It was just a thought that we were looking at for our quality measures. So Krista and I thought, if under our social history section, we've noticed, I don't think that spirometry is listed under quality measures. However, if we could check with our Athena guru and ask her that if they could create that as a quality measure, then anytime we have, they click smoking or tobacco use, something to that in that section, then it will cue them every year to request the patient as a reminder to have a spirometry test. So maybe that's something we can do, and that will help with our patient population with that.
Yeah, that's great, Luann. Thank you for adding that as well. So we are at 9:01 a.m. I don't want to hold you guys too long, but this has been such a wonderful session. So thank you all so much. I did want to make a few announcements before we part ways. First and foremost, thank you so much, Dr. Roby, for your time. That was a great perspective and didactic. So I'll certainly reach back out to you for the new year to add you to the curriculum at some point as well. And thank you to Lisa as well for the awesome case presentation. So our next session, thank you. Our next session will be on December 21st. We don't have a didactic or case right now, but I wanted to ask you all if you'd like to keep that session and still have a group discussion on, let's say, like best practices at home care. I just wanted to gauge all of your thoughts on that. Would you like to keep the session or reconvene in the new year? Any thoughts? Feel free to chat in as well. All right, no worries. We can certainly play it by ear. So I guess our next session will be on December 21st then. And if you all have any comments or discussion topics or ideas that you'd like to bring, certainly chat them in, or just bring it in live. That'll be great. So that will be everything. Thank you all so much for your time, and we'll see you guys December 21st. Take care.